Okay, so good morning and a warm welcome to everybody who joined us once again today for a webinar on the topic dementia. When I say us, I mean Ecclesia Park Old Age Home in Bleekgowrie, Randburg. Baie hartlik welkom aan almal wat vandag by ons ingesluit het. Die onderwerp is definitief iets waarin baie mense belangstel. En ons is besonder gelukkig om vir Dr. Susan Koetser, wat 'n spesialis is in hierdie geriatriese veld, vandag te kon kry om die onderwerp met ons te behandel. I think dementia is a condition or a frailty or a state that most people fear. I think it has to do with the fact that it basically attacks you as a person, that you sort of lose certain of your traits, you lose your memory. En ek kom agter daar's baie gesprekke deesdae wat nie iewers op 'n punt draai by die onderwerp van dementia nie. Selfs jonger mense, dit is regtig iets waarvan mense meer wil weet en waar ons weet baie navorsing gedoen kan word. Like with many other sensitive topics, people tend to crack jokes. I can assure you that for the family and for the person itself, it's no laughing matter, definitely a road that one would not wish to travel on. On the other hand, if one doesn't look at yourself in the mirror sometimes and smile at the strange and the silly things that people sometimes do, life could be a very boring situation. So there are different aspects of dementia. I think I'd like to introduce Dr. Koetser now. She completed her undergraduate studies in 2006 at the University of the Free State, and then completed a fellowship in the College of Physicians and subsequent subspecialization in geriatrics through the College of Medicine. She received a master's degree from the University of Witwatersrand in 2020, which focused on frailty in hospitalized patients. She has also completed a certificate in an introductory palliative care course from the University of Cape Town. She is now working in private practice at the Mayo Clinic of South Africa and Life Flora Hospital in Johannesburg, and she is also Vice President of the South African Geriatric Society. Dr. Susan is being described by her colleagues and patients as a caring, compassionate specialist geriatrician, and we can certainly vouch for that. So, Doctor, over to you, please. Thank you.
Thank you very much, and thank you very much for the opportunity to speak here today, and thanks to the organizers for all that they've arranged. Let me just see that I can share my screen. And get my talk in front of me. Okay, so today we're going to talk about dementia. I'm going to go through the topics of what is dementia, who gets it, or what are our risk factors for getting it, and how do I know if my loved one has dementia, and what types of dementia there are, as well as the treatment of dementia, and how can we prevent dementia. So dementia affects more than 5% of individuals over the age of 65 and up to 35 to 50% of individuals over the age of 85. And we know worldwide in 2013, there were about 44 million people affected with dementia. So it's really a very prevalent disease. And as time goes on, we can actually see, sorry, I'm going to get my laser pointer here. So we can see that especially in low and middle income countries, this prevalence is going to increase even further. So the dementia definition, actually in the medical world, there's been a new term for this. It's now called a major neurocognitive disorder, although most of us are still talking about dementia. It's you need to have all of these criteria to define dementia, but the important part is that there's significant cognitive decline from a previous level of performance in one or more cognitive domains. And the most common one that we know about is learning and memory, but it can also affect other domains like language, executive functioning, complex attention, certain motor skills, and social cognition, which is how you interact socially with the rest of the world. And these cognitive deficits must interfere with your independence in everyday activities. So it's not just a subjective feeling of lack of performance in these areas, it actually interferes with your everyday activity. And then we have to make sure that it does not occur exclusively in the context of delirium, and I'll talk a little bit about delirium later. And then that the deficits are not better explained by another mental disorder, such as a depression or schizophrenia, which we don't often see in older patients. It's more a disease of younger people. So just in a little bit more layman's terms, dementia is a general term for when a person has developed difficulties with reasoning, judgment, and memory, and they often have some degree of memory loss with difficulty in another area like speaking or writing coherently, recognizing familiar surroundings, and planning and carrying out complex or multi-step tasks. That is what we would call executive functioning. And these difficulties then interfere with a person's independence and daily activities. So now, how do we know what our risk factors are for getting dementia? Unfortunately, these ones that are not in bold are not really very easily changeable. So we can't die young, preferably, and we can't change our genetics. But there are a lot of risk factors that we can do something about. Smoking, excessive alcohol use, and excessive is actually more than 1 unit a day for females and more than 2 units a day for males. So that is not just, it's not a whole bottle of whiskey a day is certainly more than excessive. Diabetes, hypertension, high cholesterol, obesity, lack of physical activity. As I said, being a lower education level, unfortunately, we can't always change that, but we can certainly learn throughout life. Social isolation, and that's where COVID-19 and its lockdowns had such a big impact on dementia. Hearing loss is also a very often forgotten subject, that risk factor for dementia. It not only leads to social isolation because you can't participate in usual conversations, but it can actually physically cause brain shrinkage in your memory areas. So it has a physiological association with dementia, and depression, of course, can lead to dementia as well. So dementia is an umbrella term. We often get asked, do I have dementia or do I have Alzheimer's? And actually, Alzheimer's is a type of dementia. So it's the most common type, followed by vascular dementia. Lewy body dementia is supposedly just as common as vascular dementia, but I think it is very underdiagnosed. Then we also have other types of dementia like frontotemporal or Huntington's disease, Parkinson's disease. Very commonly, we can also have a mixed dementia, especially a mixture between vascular and Alzheimer's disease. But the important part is to know that these are all types of dementia, and dementia itself is the umbrella term for loss of memory and other thinking abilities that interfere with your daily life. So I'm just going to talk about different types of dementia a little bit in more depth. First of all, it's not really a type of dementia, but mild cognitive impairment is sometimes a diagnosis where you have memory concerns, but it's not enough to cause functional loss. We then call it mild cognitive impairment. And in this case, 1/3 of cases can progress to dementia, 1/3 would usually remain stable, and 1/3 would improve even to normal cognition again. So it's not necessarily, if you've got mild cognitive impairment, that you're definitely going to develop dementia later on. So next up, the most common type of dementias is Alzheimer's disease. It's characterized pathologically by these tangles inside your neurons, inside your brain cells, and these plaques, amyloid plaques that get deposited. So it's kind of a protein that gets deposited in between these brain cells, and it prevents the communication between brain cells from taking place as before. And it can be hereditary, but the hereditary type is usually a more early onset, so under the age of 65 years. And there's often a very clear family pattern in their hereditary type. Whereas if you live old enough, if you've got a parent over the age of 80 with Alzheimer's, yes, if you do live to the age of Alzheimer's, to the age of 80, you might get Alzheimer's as well, but it's more genetic related than hereditary. So the main clinical features of Alzheimer's disease is that there is early on memory and learning impairment. You're struggling to make new memories, and that is why the short-term memory is affected more than the long-term memory. Sometimes you can have some judgment and planning incapacity, and also some level of small motor function impairments, so that is called apraxia. And at some other stages later on, especially, you can get visuospatial impairment, so inability to judge the space around you. And then this varies very much between different patients, but you can have behavioral and psychological symptoms. So often we find that the patients early on have some degree of depression because they realize that something is not quite right and they're worried about what it might be. Later on, they become more apathetic, meaning that they just relax and they don't really want to do anything more. And very later in the disease, you can see some behavioral problems related to memory tricks or brain tricks. So sometimes having paranoia or hallucinations. And the language impairment also comes later. We can see sleep disturbances, seizures can happen in Alzheimer's disease. And they can say that sometimes early on, if you've got the sudden onset of smelling impairment, not COVID related, it can be an early sign of Alzheimer's, but it's not necessarily. So the next common type of dementia is vascular dementia. And that usually happens after an event, something like a big stroke. But sometimes you don't always see these events. You don't always know that you're having strokes. And we call that microvascular disease. So like on this brain scan, you can see all of these white parts is microvascular disease. Patient was probably unaware of that's happening at that time. And it's where Alzheimer's disease affects the outer part of the brain. Vascular dementia affects more the inner part of the brain, so we call it subcortical. And we usually have to look for the cause. So there are vascular risk factors, so that's where the diabetes, smoking, high blood pressure, cholesterol, all the things that are bad for the heart, we know are bad for the brain. And that's where the vascular disease comes in. We have got some synonyms that you might come across called SCIVIT, so subcortical ischemic vascular dementia, or the very old term for vascular dementia was Binswanger disease, but I have seen it on quite a few scan reports, so you might have noticed it as well. What we notice in vascular dementia is that they have prominent executive and processing speed impairments. So they can still do a lot of things, but it takes a lot longer, or they can't quite plan or judge how they should be doing all of these things. Sometimes they do have memory impairment, but usually they're better at learning and can recall things easier, especially if they get given a clue. We often see gait impairments, so how you are walking can be affected with vascular dementia because it affects that inner part of the brain. and together with that urinary symptoms, then we also often see something that we call Parkinsonisms. So it almost looks like Parkinson's disease, but doesn't have all the features, and there are some clues when you, as a doctor, examine the patient. And we often see that vascular dementia patients are have a lot more behavioral disturbances than Alzheimer's disease, and they almost, we sometimes call them the more difficult patients to manage. The depression also is often a big problem in vascular disease and difficult to treat with normal antidepressant. Just a quick word on Lewy body dementia. As I said, it's often diagnosed, and that's why we need to watch out for it more often. And it's important to distinguish it from your other types of dementia, because antipsychotics that we often use to deal with hallucinations, which is a presenting feature of the Lewy body dementia, can be deadly in Lewy body dementia. So we have to avoid antipsychotics in this diagnosis. They often present early on with sleep problems, and as I said, the hallucinations, and they have difficulties controlling blood pressure, and they become quite stiff, so they develop a lot of Parkinson's features, and Lewy body dementia correlates closely with Parkinson's disease as well. Then another type of dementia that is also relatively common is frontotemporal dementia, or it used to be called Pick's disease. Now, this dementia affects younger people more often. There's a behavioral variant and a language variant. And the younger people that are affected, they often have a strong family history. So it's heritable, autosomal dominant. And it's important to pick that up because you might need genetic counseling deciding to have children if you've got a strong family history of this type of dementia. It can be associated with motor neuron disease. And this dementia presents more often to psychiatrists. As I said, it affects younger people, so they don't always come to a geriatrician. And they present with severe changes in their social behavior and personality. So they develop this loss of empathy. They're very apathetic. They eat a lot. My colleague, Dr. Butler, calls it the cookie test. If you put a whole tin of cookies in front of the patient, a normal person would maybe have one or two and then restrict themselves. But a patient with frontotemporal dementia will have that whole tin of cookies before you can say, snap your fingers. The language variant of frontotemporal dementia presents with a severe difficulty in talking, and they often can have difficulty understanding certain words, and you get different types of language variant as well. So other types of dementia that we often look out for, and this is a type that can be potentially treatable, is called normal pressure hydrocephalus, where there's swelling in the ventricles, the parts of the brain that makes your fluid. And these patients present with incontinence, so they're wet, they're very off balance, they have a very typical weird balance when they're walking, so they're wobbly. And then later on in the disease, they become wacky or get dementia. So this is an acronym that the doctors learn in medical school for normal pressure hydrocephalus, wet, wobbly, and wacky. Other types of dementia that we also see, you can have dementia with Parkinson's disease. In South Africa, very prominently, we can have HIV-related dementias. Prion disease is your what is commonly known as mad cow disease. It's really not common, and it has certain clinical features. Then other weird diseases that are also more genetic is Wilson's disease with the buildup of copper, and Huntington's disease. So when we've got a patient with dementia, we always have to think, but isn't this potentially something else? And that's where we have to think of something called delirium, which I'll talk about next. Drugs that can cause symptoms of dementia, but that may be treatable if we can change these drugs. Depression, endocrine diseases, so problems with your thyroid or electrolytes like your calcium and sodium. a vitamin B12 deficiency can cause dementia, and it is potentially treatable. And then we do see sometimes patients looking like they've got a dementia, but that have actually got a type of brain tumor, and we've got to exclude structural brain pathology as well. So just going through delirium, this is an acute disease. So we often call it acute brain failure. So there's an acute change from the baseline, and it's a sudden change. It can fluctuate. So the situation goes up and down. One moment they're normal, and then the next moment they're completely funny again. You can have hyper or hypoactive delirium. So sometimes the patients get very restless and agitated, but one that is under-recognized and often occurs in a hospital is hypoactive delirium. You're just seeing, oh no, this patient is just sleeping all the time. That is hypoactive delirium. And then there's an additional disturbance in cognition. So in one of those cognitive fields, we see that there's a disturbance as well. And next up is drugs. So we know that there are a lot of drugs that can actually cause or prolong delirium or confusional states. So all of these drugs, and it's a long list, everything that a doctor, everything that a psychiatrist or even a cardiologist prescribes. Now, it doesn't mean that you've got to stop all of these drugs, because otherwise you might die if you don't have your diuretic, if you've got heart failure, and your beta blocker if you've got rhythm problems. So we just have to bear in mind that these drugs can cause confusion, and to think of what drugs we are using in patients. But then also importantly, over-the-counter drugs. So your antispasmodics, your Buscopan that you just take for a general tummy pain, and your muscle relaxants, baclofen, or over-the-counter muscle relaxants like Norflex, and analgesics, pain medication, can all cause delirium and can cause dementia in long-term use, especially certain antidepressants as well. So it's important to look at drugs when you're looking at delirium. So now a patient is thought to have delirium and they come to a doctor. How do we diagnose dementia? So we take a full history. It's very important. I spend about an hour taking a history from a patient, from both the patient as well as their caregivers or loved ones. You need to get a comprehensive history. Then we would do a full clinical examination, which would include a full neurological examination, and looking at the way that the patient walks is very important. Then we do cognitive examination, and I'm going to show you some examples of some of the common memory tests that we would do. And then we do order some laboratory investigations to look for your reversible causes. So something like the B12 deficiencies or thyroid abnormalities, those are potentially treatable, and we need to look for them, and we can't always pick them up on the clinical examination. We do brain scans as appropriate. So we always say that the further advanced dementia is, the least advanced your memory of your brain examination needs to be, because if you pick up a small stroke on an MRI that you wouldn't have picked up on a CT scan, it's unlikely to be the cause for a severe dementia. So if you have a severe dementia, you just need a quick in and out CT scan. The patient is also less likely to lie still for an hour that is required for an MRI scan. And then when they do dementia studies, so determining whether some medication is working or other studies to determine diagnosis of dementia, they would then do advanced testing. So sometimes they might request a lumbar puncture. Overseas, they can do special SPECT or PET scans, but we don't have them available in South Africa yet. And then genetic testing might be required as well, but it's not appropriate in your everyday examination, and I don't do them ever. It's more for, as I said, for trials and things like that. So some of the memory tests, you might have heard of a mini mental state examination, and we abbreviate it to the MMSE. It's a score out of 30, and it has various components that the doctor will do. And it helps us to look for more advanced types of dementia, or you can use this test in patients that have got a lower education level. We always do a clock drawing test together with the mini mental because it gives us a little bit more insight into their executive function. The MOCA or Montreal Cognitive Assessment is a more comprehensive test and more useful for early onset disease or for your vascular dementia. It scores a little bit, it tests a little bit more of the executive functioning. Sometimes doctors might just do what we would call a mini cog, just a screening test for dementia. So you just ask them to recall 3 items and draw a clock at the same time. And if there's an abnormality, you know you need to go into more comprehensive testing. If it's normal, it's unlikely to have a significant dementia, but but it needs to be done correctly as well. So now you're probably thinking, oh, so why should I think someone's got dementia, but why should they still be referred to a doctor and have all of these tests done? So first of all, doctors can do a formal diagnosis, which may be useful for claiming from medical aids or for claiming from special funds, insurances and those kind of things. It will also be, we also have to exclude the reversible causes. And then we specifically look at the safety of a patient. Is this patient still fit to drive? Should they still be living alone, or maybe they need a little bit of help at home? Are they eating well? Are they taking their medication correctly? And then, as you saw, there's a long list of medication, and it's important to review all of those medications and see whether they can be adjusted safely, and then whether potential therapy is possible for the diagnosis that you've made of dementia. So now, how do we manage dementia? Unfortunately, there is still no cure at the moment. So our aim is to improve your quality of life for both the patient as well as the caregivers and family. And then we can try to slow down the progression in certain cases. So non-pharmacological interventions is the most important intervention. Nutrition is the best, and you don't have to go on a special diet. The Mediterranean diet is a very balanced, everything included diet, so everything in moderation, even that 1 glass of wine if you don't have a high falls risk and other risk factors for alcohol. But it includes carbohydrates, it includes oils, it includes lots of fresh fruit and vegetables, and fish preferably, and then to a limited degree, other animal-based protein. And then rehabilitation is also very important, physical exercise. My dad one day I was telling my dad, oh, I don't think I want to go to work today. You know, it was one of those rainy days you just wanted to lie in bed. And he said, okay, you'll come to work on my behalf, because he knows what to do with my patients, just tell them to exercise. And I said, yes, that's right. It is my most common prescription is exercise. And not just physical exercise, but brain exercise as well. And that includes social interaction. And as I said before, COVID was really bad for dementia patients, especially because now they couldn't have their access to their weekly physical exercises. The biokineticists weren't coming to do all the group classes anymore, and they didn't have that social interaction with their friends and family that is so important for your brain. So just more benefits of an exercise program. It also helps to prevent falls, and it helps your gait to be normalized. It can slow down cognitive decline. It improves your overall physical function and can keep you independent for longer. It decreases depression, and it helps you to set a routine and helps improve sleep cycle. And even in very advanced dementia cases where we would do palliative care, so end of life care, exercise and physiotherapy can help to prevent pressure sores, fractures, and pneumonia. And it also provides support to the caregivers First of all, there's that half an hour every couple of days where they don't have to spend all the time with the patient. And it also helps with all behavioral problems, having that exercise program. The next up is how to cope. First of all, when you're a patient with early disease, having been diagnosed with dementia. So you have to look after your health, both your physical and mental health. Go for regular checkups, take your medication if needed, have a healthy diet, enough sleep, and avoid risky activities. Talk to others to discuss your feelings, especially when you've just been diagnosed with a serious illness like dementia. It's important to tell your loved ones and to discuss it. Also discuss what plans can be made, what your wishes are as the disease progresses, for more help with your daily tasks like bills and housekeeping before you end up in a situation where it's too late. And discuss and appoint a power of attorney and a healthcare proxy before a crisis. So discuss where you want to live, who will make healthcare decisions for you if you can't make them for yourself. And also, unfortunately, in reality, who will pay for this care? And what are my wishes for my health if I am no longer able to do certain things? Example, do I want to be resuscitated? Do I want feeding tubes? And all of those types of things are very important to discuss with your loved ones and eventually with your healthcare worker as well. Now, how to cope if you are a caregiver, and I think we're having a talk on this in 2 weeks' time as well, because this is definitely easier said than done. It's important to try and make a routine with a daily plan, but you must be flexible if the plan doesn't work out that day. Try to be patient when responding to repetitive questions, behavioral statements, and I know it's very difficult to answer the same question again and again, but be creative. Try not to argue or confront a person when they have mistaken ideas or facts. Try to either change the subject or gently remind them of the inaccuracy, but don't force it on them. If they've got this idea stuck in their heads, there's no point in fighting about it. You will just upset yourself more likely. Use memory aids. So, for example, writing down usual tasks and putting it up on the fridge where you know the person will see it. Establish calm and consistent nighttime routines and leave a night light on. Avoid major changes to the home environment. So patients with dementia can remember things the way they were. So try and keep them that way. Don't try and reshuffle the living room now all of a sudden. Employ safety measures in the home. Make sure there are grab rails in the bathroom. Help with personal care tasks as needed. And you don't have to bath every day if bathing is a big issue for this patient. Speak slowly and only give one idea at a time. You give a long list of instructions, they're only likely to remember the first one and won't perform the other ones either. So one idea at a time. As I've said, encourage physical activity and exercise. If you realize that you are getting burnt out as a caregiver, take care of yourself and consider respite care. So consider having someone come over and you taking a little holiday, even if it disrupts the usual routine, or having your loved one placed in a care facility for a period of time. Doesn't have to be permanent, but just to make sure that you don't burn out. And join a support group. Look out for support groups in your area and try and join them. And if you can't find a support group, try and create one. You don't always have support groups available, and we can always learn from one another and try and create one if you can't find one in your area. So pharmacological management from a doctor's point of view of dementia, unfortunately, we're very limited in this area. We do try to treat the underlying cause. So for example, if you've got vascular dementia, we would give you a statin, not only to limit your blood or your cholesterol levels, but it does have a degree of treatment for that inflammation in those little blood vessels. Aspirin isn't always useful unless you've had a big stroke, but it's not useful in the mini strokes that we see. Then we get a drug called or a drug group called choline esterase inhibitors. The most commonly prescribed one is called donepezil, but we also get galantamine in South Africa, and we used to have rivastigmine. I don't think it's available anymore, but those two are very expensive, and we only use them if the patient was doing very well but developing side effects on the donepezil. The choline esterase inhibitors increase the neurotransmitters in the brain. So there where those tangles and plaques were deposited, it helps to increase the fluid there so that their communication can take place a bit better. So that's why it's mostly indicated for Alzheimer's disease or some of the atypical dementia. It really doesn't work well in vascular dementia. Then we get something called NMDA receptor antagonists, or memantine. This is for more advanced disease. It doesn't really have a benefit on the actual cognition, but it can help to keep you a little bit more functional, and it can help to help with some of the behavioral and mood symptoms that we find in the dementias. But once again, mostly used for Alzheimer's disease rather than vascular dementia. Then some of you might have heard last year there was big hoo-ha about this new drug that was launched that can cure Alzheimer's, and it was on BBC breaking news. Aducanumab, it's a very big word. Unfortunately, it's not such a miracle drug. Yes, it can take away those plaques and tangles that we saw in the pathology, but even in rat studies, they found that even if you take away those plaques and tangles, it does not improve the actual memory. It might, in the human studies, it showed benefit almost in patients, the ones that had a very strong family history, but almost before they even developed the Alzheimer's, it might have a benefit. But it also had some very serious side effects in terms of causing bleeding on the brain or swelling of the brain. So it could cause more damage than it could do good. And it's not available in South Africa, and it costs about $60,000 a year. And you'd have to go to America once a month for a drip to get access to this drug. So I don't have any patients that would be a candidate for it, even if they had the money. I wouldn't advise it. So I know everyone is taking their omegas religiously to prevent their dementia, and they're taking all their supplements. Unfortunately, we know there are therapies that are proven not to work. High-dose vitamin E and salicyline can actually cause damage, and high-dose vitamin E can cause cancer. So we don't advise it routinely in patients. Vitamin E would only be prescribed in patients with severe liver problems where they can't store the vitamin E. Salicyline estrogen replacement doesn't help, so there's no use in starting granny on hormone replacement therapy at the age of 70 just for brain health. Ginkgo biloba can also cause more damage. It has a lot of interactions with other medications that older people are often on. And as I said, the omega-3s doesn't really have side effects. It can thin your blood a little bit, so it's important not to take it before operations, but it has no benefits in terms of cognitive health. And they've also recently shown it doesn't help for heart health either. So, and also not in joint health. It only might have a benefit in eye health. So if your eye doctor prescribes it, then you should take it. Lastly, just can I prevent dementia? Unfortunately, you can't prevent how old you're going to get, or hopefully don't want to prevent that. And you can't change your genetic layout. You can limit your risk factors, so control your blood pressure, your sugar, and your cholesterol. You can do physical exercise, can do cognitive and social stimulation. You can follow a Mediterranean diet, and don't smoke and limit alcohol. So thank you very much for your attention. I will be taking some questions now.
Sure, Dr. Kutcher, that was extremely interesting, very thorough, and still to the point and very understandable. it feels like I would really love more people to watch this afterwards. So from our side, just one question, and thereafter I will give you the questions from the people who watched. With severe dementia, bladder control becomes a problem. We do find that doctors prescribe Vesicare. How do you feel about using it for these specific patients?
So Vesicare, unfortunately, is one of those drugs that fall under the ones that can cause confusion. It's got what we call a high anticholinergic burden. The studies initially showed that it was safe, but they only studied it for 3 weeks for cognition. And we know that you never use it just for 3 weeks. So we use it for longer, and we don't advise Vesicare. It can worsen confusion. We know that the bladder problems are a big problem. There is an alternative drug that is made, I think, by the same company as Vesicare also. It's called Impairme, but it has got benefits, but only in 60% of cases. But it works only directly on the bladder, so it doesn't have the brain side effects, which is why we would rather use that. But unfortunately, it doesn't work in all the cases. And then we have to go with more going regularly to the bathroom. So setting an alarm clock to go every 2 hours, just for in case, wearing protective devices to protect, I call it dignity protectors. And those kind of things are more important and avoiding nighttime drinking, but don't drink too little during the daytime. A lot of people don't want to go to the toilet, so they don't drink water, and that's bad, actually.
You might have touched on a topic. Well, I heard you mention paranoia. That, you know, when it comes to day-to-day functioning, that's one of the behavior patterns that cause a lot of interpersonal problems, because, you know, people get blamed for taking things, for actually going into rooms and flats and things. Treating paranoia, is that, or treating those sort of those types of behavior, what do you say about that? Yeah.
So yes, paranoia is a very difficult behavior to treat. We don't want to go medication route necessarily. So first of all, we use a non-pharmacological approach. So with that, we say, we call it the TADA approach. You tolerate and anticipate and don't agitate, so TADA. So you tolerate when a patient has got some paranoia, say, oh yes, I think that might be missing, but don't blame anyone else, obviously. And so we'll look for it later. Anticipate when a patient might be looking, if you know this person's always looking for their handbag, and you know that that's just where they hide it away, or they often put it away and they forget that they put it there. Make sure you know where it is so that you can go and get it and say, oh no, look, we found the handbag, it wasn't stolen, it was just misplaced. So reassuring them, and don't agitate. So don't say, don't keep fighting about the same thing. Rather, just go with the flow and try to change the topic, as I've said. If you have to medicate, then we always say, start with the lowest dose, start low and go slow in older people. All of the antipsychotics can actually worsen confusion, and so they can cause disorientation, and they increase the falls risk. And falls, obviously, very bad in older people as well, and the falls risk is already increased with dementia itself. So last resort is pharmacological management.
I hear what you say about the disadvantages, but do they actually work if it's really there no alternative?
Yes, they do work in some cases. So you have to find a balance, and you sometimes have to try different drugs on different people. And we often add an antidepressant if the patient's very agitated. Sometimes the antidepressants have got less zombifying effects, but they can still help calm the patients down, especially your older generation antidepressants. So what we call the SSRIs, or selective serotonin reuptake inhibitors. They work better for these anxiety, anxious, paranoid patients. and then your antipsychotics can work as well, but low doses.
Understand. Yeah, because we find it quite interesting that they forget everything else, but that specific delusion about some, and it's not just a general one, it's they can sometimes choose one person and decide that one is out to get them, you know.
Yes.
But I won't generalize, but we do find that, and you know, if they forget about it, it's easy to handle. If they sort of remember it from the morning till the night, then it becomes a bit of a problem. Okay. From the list, from the people, there are the following questions. Okay. Roan Alex asked, is vascular dementia genetic? Is there something to do with arteries to the brain? I think you have really explained that. I think, Roan, you can also watch the presentation later on again if you want to hear the whole. Abongle asked, she's concerned about headaches and forgetfulness. Is it a reason for concern? I would imagine the headaches is another factor here. Is that part of the problem?
Yes, so headaches can be a symptom. If a patient was prone to headaches their whole life long, then it's obviously, it depends on the duration of the headaches and onset and those kind of things. But if you have headaches and forgetfulness, I would go for a clinical review, good overall review, because there can be an association. It depends. It's very,
very difficult to say.
It could be something like a blood pressure, high blood pressure, that's causing the headaches that thing and contributing to illness at the same time.
Yeah. Lindy Bebe asks, how common are seizures in dementia? Should we be concerned if a loved one suffers from multiple seizures per day?
Yes, definitely. Seizures are more common in dementia. So first of all, in Alzheimer's disease, because of those plaques and funny deposits in the brain, your electricity is not conducting as it should, and you can have seizures. So if a patient, and that is one of the things that we look for if a patient presents with delirium, so there isn't always the history of what everyone knows as seizures, where they go stiff and shake. You can have just collapsing, unexplained collapses or falls, and you have to evaluate for seizures. And you often have to do a longer term EEG, so the brain test where they look at the brain's waves over a 24-hour period, unless you actually see a seizure happen. And it's important to treat the seizures at the same time then as well. So if a patient is having multiple seizures per day, that can cause brain damage. It causes structural brain damage and worsens the dementia as well. So seizures are both because of dementia, and the dementia can get worse because of seizures.
Yeah, that's a cause for main concern. Jacqueline asks, where can a genetic test be done to see whether you've got, whether you've inherited it, whether you've got the predestination for it?
So you can talk to your local laboratory. It depends on which areas you're at. I know there's a laboratory, I think here at Flora, there's a genetic laboratory, but also the Wits Donald Gordon Hospital has got genetic studies. But it's very, very important if you want to do the genetic study that you go for genetic counseling first. You can pay, if you've got lots of money, you can just pay and have this test done, but then it doesn't come with the appropriate counseling. What if it's positive? Then how are you going to react? You need to have this proper support systems available. And also, why we don't do genetic testing for the ApoE4 allele, which is the one for Alzheimer's disease, is because it can come back as positive, but you don't necessarily you don't know that you will get dementia. And it can also come back as negative and you can still get dementia. So it doesn't help that you're now reassured, oh, I don't have the gene for Alzheimer's, but then you go and smoke and drink 10 beers a day, and then you can still end up with dementia. So it's not it's not that useful. And because there's no treatment for the dementia, even if you come back as positive, what treatment are we going to give you? It's a big ethical question whether you should be doing these tests as well.
On the other side, you can become so anxious about the fact that you do have the genetic predisposition that you might worsen your own mental functioning. Tepo asked, do public hospitals treat people with dementia?
Yes, they do. So I've got two colleagues in public hospitals at the moment, one at Charlotte Maxeke and one at Helen Joseph Hospital. And but a lot of the dementia patients also go via the neurology or psychiatry departments. They don't have access to the choline esterase inhibitors and the memantine that I mentioned, but they do have access to all the primary of the other preventive or secondary prevention drugs like the cholesterol pills and blood pressure and those things. So they definitely do treat dementia, and they can offer support as well.
Okay.
It affects everyone.
Then the million-dollar question, how do you deal with a person who has dementia but is not aware of it themselves because of memory loss and cognitive decline?
So it is a tricky one. I often, my patients often ask, should they tell their loved one? Or then I say, yes, you should tell your loved one because they deserve to know that they've got a what their diagnosis is. I often ask my patients, do you want to know your diagnosis? And then I will tell them and I will ask them, do you want to know more about it? And offer whatever advice. If they forget about it the next time, you can remind them gently, but try not to rub it in. Don't go every day, oh, you've got a dementia, and using the word has got a lot of stigma to it. So I often use a softer word like memory illness to reassure them rather than rubbing it in and making them worry about it. And if they keep forgetting about it, just ignore it. Rather, don't rub it in all the time. It's not use. It just agitates them, and they're still going to forget. And you have to go through that same grief every time.
Yeah, exactly. Can be very confrontational. Hey?
Yes.
Just two more questions. Tepu is concerned about the effect that the COVID vaccine had on persons with dementia, or I'm not sure whether he thinks it might have worsened it or what the theory is there.
Okay, so with regards to the COVID vaccine, I'm definitely pro-vaccination. We haven't had any documented studies, have not shown any problems with cognitive issues there after the vaccine. The only risk factor of the vaccines is the small risk of clotting, and that is mostly in younger people. So I actually found that my older patients had a lot less side effects than the younger patients. I know there are patients that insist that their memory problems only started after they had their vaccine. But if you go back finally and without glasses, looking out of the box, you will find that there probably was some decline even prior to that. And just because there's something that you can associate it with, you want to blame it on that, but it's not necessarily. There's absolutely no studies that show that there's any cognitive decline associated with the vaccines. However, COVID itself has had cognitive decline. So having had COVID is a bigger risk factor for cognitive decline than the COVID vaccine. So once again, the vaccine helps prevent that as well. But I've certainly seen a lot of patients that I know had some cognitive issues before they had COVID. They didn't have the vaccines and they're unable to recover after the COVID. It just knocked them completely to another different baseline.
Thank you. And then another question about drugs. What are the preferred calming drugs for daytime and nighttime restlessness? Asked by Nilesh Patel.
Okay, so once again, drugs are the last resort, and it is, it depends on the patient and their responses. So, and their falls risk and kidney function and a lot of risk factors. So I can't say there's any specific drug. We usually use the SSRIs, as I said, for some calming in the day, and then maybe a low dose antipsychotic at night. We really avoid benzodiazepines, the sleeping drugs and calming drugs. Because of their addictive effects, they have more falls risk. They're generally, we don't advise them at all in older patients. But if you were to look it up, both the antipsychotics, it's also off-label use. They're not meant for use in agitation with dementia. It's off-label use. They were made for schizophrenia and bipolar psychotic patients. They weren't made for what we're using them for. And that's important to bear in mind.
And then I'm afraid this has to be the last question. Samantha asked, what about triggering aggressive behavior? Would you say there are certain, and I think she talks about, the way you treat a person like that. I think this is also something that we will address in our next webinar, but if you could give your opinion on that, please.
So you try and avoid the triggers. If you see this triggers something, then you know, okay, no, don't do that again. If it's something that is unavoidable, so something like having to bathe, I know that's a big issue often in dementia patients. For some reason, they develop a fear of water and they don't want to shower every day. So then, as what I said, you don't have to shower every day. Just make sure that the basic parts are kept clean for basic hygiene, but you can shower every second or third day maybe. And if hair washing is a big problem, only keep that limited to once a week, or try and avoid the triggers and make them a positive experience. You can, it's like dealing with a toddler sometimes. You have to bargain and bribe, and white lies are acceptable. You will still go to them. So white lies are very acceptable, and it's okay. Whatever necessary to lessen the trauma for the patient.
Yeah, we find that whatever you do, just treat them with dignity and respect, because they do sense it. If you treat them like a child, talking down to them, that doesn't work.
Yes.
Sure, Dr. Susan, thank you so much for the time and for all the information. We'll definitely have to listen to this again. And also, all the staff here will listen to that. And then I'd like to remind everybody of the next webinar on actually the managing and caring for the patient with a dementia on the 14th of September. And we'll have a very qualified and experienced talker on that as well. But for today, thank you so much. We take our hat off to you. Thanks.
Thank you. Thank you for the invitation.
Thank you. Right. Bye-bye, everybody.